Unfortunately, breast cancer affects 1 in 8 or 1 in 9 women in the United Kingdom. So every lady that's born in this country at the moment, they stand a 1 in 8 or 1 in 9 chance of developing breast cancer. As you can see, it's very rare under the age of 40, but it increases into your 50s and 60s and beyond. So what's the solution to this big problem? Can we prevent breast cancer? Can we obtain an early diagnosis to give us a better outcome and an improved survivorship? The story goes that the previous Pope arrived in the United States on a visit, and he was whisked away from the airport in a stretch limousine, armour-plated, blacked-out windows, and as he was being taken along the freeway, he knocked on the partition and he asked the driver, he said, "Back in my country we never have cars like this." He said, "Please give me the opportunity of driving such a beautiful car." So the driver said, "Of course, Your Holiness," and they swapped places. And the Pope sat in the driver's seat and he put his foot down, 50, 60, 70, 80 miles an hour, and suddenly a blue light comes across, the local cops pull him to the side, knocks on the blacked-out window, the window comes down, he gets a shock, sees the Pope sitting there. So he phones police headquarters and he says, "I got a problem here, I stopped this car and there's a very important person driving." So he said, "Who is it? Chief of police?" He said, "No, more important." He said, "The governor?" "No, more important." "The senator?" "No, more important." "The president of the United States?" "No, more important." He said, "Who could be more important than the president of the United States?" He said, "I don't know, but the Pope's driving him." So why do I tell that story? Because we all look to authority. We all look to people who are supposedly in authority. We look for guidance. And over the last few days, we've heard from renowned professors, we've heard from very intellectual-looking people. We've seen on the headlines of the Daily Telegraph the dangers of having breast screening. And I think it's very, very important for me to go through today all you need to know about breast screening so that you can make your own mind up. And I hope when you come away from here, you will be able to make your mind up. Hopefully you won't go away brainwashed, you'll go away informed. So what do I want to cover? I want to cover prevention and breast awareness. I want to cover the science of breast screening. I want to explain a little bit how breast cancer develops and how screening can be influential. I want to talk about the benefits of screening. I want also to talk about the downsides. I want to talk about the balance between those benefits and those downsides. Talk a little bit about the programs for screening, and then just at the bottom to summarise where we've got to. So next slide, please. Prevention and breast awareness. Well, we can look at the personal risks. Unfortunately, some of those risks, some of these factors which put people at more risk of breast cancer, we can't control. We can't control our family history. If our mother and our grandmother or our sister had breast cancer, there's nothing that we can do about it, but it is a risk. Our age, unfortunately, there's nothing we can do about that. As we get older, our risks increase. Hormones, whether you've been on the pill, whether you're on HRT, that increases your risk. I put a little star there. It is something you can do something about. You can, if you're on the pill, or if you're on HRT, you can consider coming off and reducing your risks. Smoking, it's got 2 stars on. I noticed that the person in charge of the school mentioned that it's a no smoking zone. Really, for ladies, their life should be a no smoking zone because it considerably increases your risk of cancer in general, but breast cancer in particular. Weight, again, something with two little asterisks. You can control your weight, and again, if you're overweight, the risk of breast cancer is increased. Parity, that means the number of children you've got, and breastfeeding. The more children that you have, the more you breastfed, the lower the risk of breast cancer. Alcohol, and again, I'm sorry, it's got 2 stars. The more that you drink, the higher the risk of breast cancer. And I know that's a very particularly sad fact for me in particular. I think one of my professors once said to me, the definition of an alcoholic is someone who drinks more than his doctor. So you've got plenty of scope. And finally, exercise. It's independent of weight. So in other words, even if you're thin and slim, you can contribute to reducing your risk of breast cancer by doing exercise as well. And likewise, if unfortunately you're overweight, even if you do exercise, that will reduce your risk of cancer development. And these are 2 areas that have received a lot of attention recently, not only for the general population, but also for ladies who've been diagnosed with breast cancer. Exercising and being slim considerably reduces your risk of the breast cancer coming back if you've had a diagnosis. Next slide, please. The science of screening. What do we mean by screening? We mean that we can use either an examination, examining yourself, or a test, such as an X-ray or a scan or a smear, to detect disease at such an early stage, or even before the disease actually becomes apparent. So what does that mean? It means that before you develop a lump in your breast, there is the ability to pick up a problem at such an early stage that it hasn't really developed into a lump yet. Now, obviously, that's very, very important in making sure that we can pick up disease at a very early stage. Early detection will lead to much less unpleasant treatment, and most important of all, a better outcome. The chance of cure is much higher. So if we pick it up early, it's logical, the treatment is less unpleasant, and the chance of cure much higher. And I'll go into this in a little bit more detail later. Of course, any screening program is very important to do no harm. Okay, so there's no point having a wonderful test that picks up every possible problem but kills half the patients due to another side effect of the test. Next slide. So how does breast cancer develop? It's important to understand this because it's only then that we understand how we can pick it up early. It starts off, we all have normal breast ducts, men and women. Unfortunately, in some ladies and men for that matter, there's an overgrowth. The duct cells, the cells within the ducts, the milk ducts of the breast, begin to overgrow. But they're normal. So there's no problem, but it's a beginning of a warning sign. If that process continues, the overgrowth of these cells within the ducts become abnormal. Still not cancer, still not even pre-cancer, but a significant warning sign. And then finally, we get overgrowth of cells which are cancerous within the ducts, but they still are within the ducts, so they can't spread. But they are cancerous cells. And I'll come back to that in a moment. And then finally, true cancer, the cells are spreading out of the ducts into the surrounding tissues. That's called a malignant cancer. Next slide, please. Don't know how this will come out. No, not very well. But basically, these are the normal cells in the ducts. These are an overgrowth of normal cells, then slightly abnormal cells. And here are the cancer cells that are bulging the duct. But you can see that they haven't spread out yet. They're not spread out of the duct, and removing them will cure the patient. If a patient has that type of pre-cancer, then removing it is 100% curative. So the aim of screening is to try and pick up things at this stage when you can say removing it will be curative. Once it's got to this stage, even if it's early cancer, it can spread anywhere else in the body. Next slide, please. So what methods do we have for screening? Well, we can examine ourselves. We can use a mammogram, that's an X-ray of the breast. We can use an ultrasound scan, or we can use an MRI scan. Next slide, please. Well, unfortunately, examining ourselves is not very useful, of limited value, because it's difficult to tell between what's normal and what's abnormal. And doctors and nurses are the worst patients. It's very difficult to assess yourself. Because you feel a bit of lumpiness, you think, oh my God, this is it, this is a breast cancer. And of course you go and have it tested out, and 19 out of 20, 95% of times, it's nothing at all to worry about. So it's not a very reliable test. And of course, you can't pick up anything before it's feelable. Whereas a mammogram, although it is rather complicated and complex to see the X-rays, it's a painful, anyone who's had a mammogram will know that it's a painful thing to have. It is quite expensive. There is some radiation involved, and I'll talk about this. There is X-rays involved. But the pickup rate is 95%. In other words, if you have 100 cancers, 95 will be picked up on the mammogram. So it's pretty reliable. But in 5% of ladies having a mammogram, they could have cancer, but it won't show up on the mammogram. So it's called a false negative. It's a negative result, but it's falsely negative because there really is a cancer there. But it's a good 95% are picked up. So it's a good test for breast cancer. Of course, if you're thinking of a screening program and putting hundreds of thousands, millions of women through this, you've got to be careful that you don't pick up a lot of non-worrying things. In other words, what we call false positive, where the radiologist, the X-ray doctor, looks at the X-ray and says, that's a little bit worrying. We better call the lady back for some more tests. That's not good for the lady, you know. She gets the phone call to say you need to come back for more tests, and of course she fears the worst. She doesn't sleep for a week while she's waiting for the appointment, and her life flashes before her, only to be told there was nothing to worry about in the first place. So we have to minimise the number of what we call false positives. Now, for every 100 ladies that have a mammogram, in about 5 or 6, they have to come back for further tests. Thankfully, only 1%, only 1 out of the 100, actually needs to have a biopsy, and only 0.6%, or 6 out of 1,000 women that come for a mammogram, so women coming off the street, and I'll talk about the age group, etc. in a moment, 6 or 7 per 1,000 will unfortunately have, without them knowing about it, an early cancer in their breasts. So again, 1,000 women, 994 will be told everything is fine, but for 6, they will have a diagnosis of an early breast cancer. Next slide, please. Now, there are 2 other methods, ultrasound scanning and MRI scanning. Ultrasound has its attractions because it's painless and there's no radiation, but it's not very good at picking up cancer. MRI scanning is brilliant at picking up cancer, but it's and there's no radiation, no X-rays, but it's very expensive. It takes a long time for each scan, and every time a person needs an MRI scan, they have to have an intravenous injection into their vein. So it's quite a big issue, and not yet practical to have as a screening tool. So we're left really with the best method we have at the moment for assessing the breast is a mammogram. Next slide, please. So, the big issue. What are the benefits of screening? What's the benefits of going up and having a mammogram? Well, as I said to you, I haven't put it here, and it's not something that's discussed very often with statistics, but I deal with, and this will be a theme over the next quarter of an hour or so, I deal with real people, real women, real families, mothers, sisters, grandmothers, etc. And if 996 get reassurance then that's an amazing psychological benefit. Nowadays, I don't think there's a person that I've met that doesn't know someone who's had breast cancer. I don't know a lady who doesn't wash herself and wonder, are my breasts healthy? You go up, you have your mammogram, you get a letter saying, all's clear, suddenly it's euphoria. As I say to my ladies when they leave the room, you can walk out of the door with a skip in your step, and you can, you know, life can begin all over again, all your worries. And that benefit is something that is so important to real people. It's not something that appears in the statistics. It's not something that's really discussed very much, because statisticians don't appreciate this. But real women with real anxieties are really reassured by a mammogram being normal. So I think that's very important. However, what happens if you are destined to develop breast cancer and it's picked up on the mammogram? Remember I said, if we can pick it up at that early stage, if we can pick it up when it's a pre-cancer, if we pick it up when it's a tiny little shadow that you can't feel, it's going to be smaller, it's going to be less aggressive, it hasn't spread to the lymph glands in the armpit, that's where breast cancer will normally spread to. Your outlook will be very much better. The need for a mastectomy to lose the whole breast will be considerably reduced, and because it's been caught at an early stage, the need for horrible treatments like chemotherapy will be considerably reduced. And the bottom line is a very high cure rate. And I'll talk about it in a moment, but basically the last statistics were when we looked at 10,000 women who were diagnosed with breast cancer on the National Health Service breast screening program. If we look in 5 years' time, 96% of them are perfectly well. The cure rate is nearly 100%. So if you're going to develop breast cancer, if you have it picked up on a mammogram, the chance of you being cured is close to 100%. Next slide. So what's the evidence that it works? Well, I've just said, here we are, 10,000 patients, 96% alive. Now, a lot of these studies are a little historical because screening has become so accepted throughout the world that it's very difficult to do trials nowadays to do research onto whether screening works or not. You see, if I said to you today, right, we're going to draw a line down the middle of this room, everyone on this side of the room, you're not going to have screening. Everyone on this side of the room, you are going to have screening. And then we'll see how it goes over the next 10 years, and we'll see how many women are alive here in 10 years, and how many women are alive here in 10 years. And yes, we'll probably get a very good idea that the women who have screening have a reduced risk of dying of breast cancer. But I can tell you, the women who are, as it were, randomized, who are chosen not to have screening, will all jump up and say, no, I want a mammogram. So it's not ethical. We can't do those tests anymore because women will not agree not to be screened. Do you understand? So we can't do the sorts of trials that we would do, say, with a drug. If we discovered a new drug, what we try and do is try and give half the population that need it the drug, and half the population a dummy, and then see who benefits and who doesn't, and we can then know for sure whether it works or not. With screening, we can't do it, but historically, in Sweden, they started screening in 2 counties, and in 2 other counties that were almost identical, they didn't do screening. And what they found were those people that attended for their mammograms, the chance of dying of breast cancer was almost halved. Overall, in the whole population of women, some who came for screening, some who didn't, the risk of dying of breast cancer was reduced by 20 to 30%. So these were the first studies which made people say, hey, this is something, women are dying unnecessarily from breast cancer. If we can pick it up early, we can demonstrate that fewer women will die of breast cancer. Next slide. However, as usual, whenever we make a statement, there's always someone to disagree. They would say, oh yes, all very well, what you're doing is by picking up these very tiny breast cancers, you're selecting out the good cancers that are very slow growing, Yes, we pick them up at an early stage, so early that, of course, people live longer with their breast cancer. And as I said to you, trials are very, very difficult. So that's why we have this controversy at the moment, because it's impossible for us to prove exactly the benefits of having a regular mammogram. Next slide, please. So, people have been talking over the last couple of days about the downsides of having a regular mammogram. We've talked about the benefits, so what are the downsides? There's radiation, that's the x-rays you have every time you have a mammogram. There's something we call overdiagnosis, I'll talk to you about that in a second. Overtreatment, I'll mention that in a second. Anxiety, obviously, you get the letter in the post, please come up in 2 weeks on Wednesday for a mammogram. You start, the butterflies start in your stomach, you worry, you come up, you have the mammogram, you have to wait 2 or 3 weeks before you get that letter in the post, you open it with shaking hands, oh, thank God it was okay. Enormous amount of anxiety. And of course, as we said before, mammograms are uncomfortable. I think one woman said that if men had to have mammograms, they'd have designed another way of looking at the breast. Next slide. So let's look at the radiation, because I think this has been one of the principal arguments that's been raging. The first thing to say about the radiation is that because anyone who's had a mammogram will know that the breast is crushed, I think that's probably the best word to say, squeezed is a gentle way of saying, between two plates. So there's very little radiation that goes anywhere else except for the breast. So you can be pregnant and have a mammogram, it won't harm the baby. Now, if we compare the amount of radiation in a mammogram to other tests, you'll see it's very tiny. And the answer, why is that? Because the breast, as you know, are generally very soft. If you compare that, say, to having an x-ray of your spine or your leg, you need a lot of x-ray power, as it were, to penetrate the bone. So you need 6 mammograms to be 1 barium swallow. You need to have 30 mammograms to be the equivalent of a computer scan of your chest. So if you come into hospital, you know, with query pneumonia, and the doctor says, we're not sure quite what's going on, you need a CT scan of your chest, that would be the equivalent to 30 mammograms. If you come into hospital and you've got abdominal pain, you've got pain in your tummy, and they say, not sure you've got appendicitis or colitis or something, we need to do a CT scan of your tummy, that's equivalent to 50 mammograms. So you can see that although there is radiation in a mammogram, it's a relatively small amount of radiation. However, we know that ladies have these on mammograms on a regular basis. So how does it compare with general living? Well, if you are lucky enough, well, not at the moment, I don't think you can, fly to America. If you fly to America and back at high altitude, you get the same amount of radiation flying at altitude that you do from a mammogram. If you live for 2 months in London, the ground beneath us contains a small amount of radiation, and over 2 months, we will receive the same amount of radiation as you get in a mammogram. Okay, remember that. And if you're lucky enough to live in Cornwall, where the radiation in the rocks is a little bit higher, in a matter of 3 or 4 weeks, you will get the same radiation as you get in a mammogram. So it's very important to get it into perspective, and perspective is such an important word. Yes, there is radiation, but it's a relatively small amount, and even if you have 25, 30 mammograms in your lifetime, it's still only a relatively small amount of radiation. And don't forget, the risks of radiation are mainly theoretical. No one's ever shown that having mammograms increases your risk of breast cancer. It's never been shown. Where they have extrapolated, where they've got their information on the theoretical risks is from Japan, Hiroshima, when they dropped the atomic bomb. The people that were a mile away from the centre of the blast received a certain amount of radiation, and a certain percentage of them developed breast cancer, or any cancer actually. The further away you were, the lower the risk of cancer. And from that, they have extrapolated. And I think it's obviously very, very unfair, because clearly the sort of radiation that people were receiving... yes, still working? Am I running out of battery? The microphone's running out of battery. Right, I think that's working. The amount of radiation that we're talking about was horrible atomic radiation, very unrefined. The radiation in a mammogram is beautifully refined, very, very carefully checked. And the amount of monitoring of how much each mammogram produces is very, very, very carefully assessed. However, the people who have assessed this would say that for every 10 screening mammograms that a woman will have, so if you have one every 3 years, you'd have to start at 50 to 80 to have 10, so it's a lot of mammograms, you will induce less than 1/100th of the natural number of breast cancers that will develop. So it's really, even the theory of it is that the actual extra number of cancers will be small. And what we have to do always in this is look at the risks of having the radiation against the benefits that you'll get. Next slide. Overdiagnosis. Well, this is what we were talking about before. The 5 or 6 women that are brought back and then told that there was nothing to worry about in the first place. Causes anxiety, sometimes they have to have further x-rays, further scans, sometimes a biopsy, which can be very uncomfortable. They may even have to have an area surgically removed, they may even have to have an operation. And then they'll be told that there was nothing to worry about in the first place, it was normal. Now the critics of screening will say, isn't this terrible? You caused all this unnecessary problem. And there was nothing wrong with the lady. Had she not had the mammogram, she'd never have had the anxiety, she'd never have needed the further x-rays, scans, biopsy or surgery. And it's a legitimate criticism. However, again, I'll come back to this, real women, people who I meet across my consultation table, when they go through this, they are delighted that it was nothing to worry about. And usually, they are the first in the queue for the mammogram next time, because people want to know what's going on in their body, and if it requires a few extra tests to confirm that everything is fine, then they're happy. So although statistically, yes, there are many thousands of women every year having so-called unnecessary tests, the benefits to that individual woman, that real woman, I think you can't overestimate. Next slide, please. Now, this is what's been this slide is the topic that has been exciting the media and the professors over the last couple of days. It's a problem of our success of picking up problems within the breast at such an early stage. Pre-cancer. It's not even a true cancer yet. We pick it up. We can pick up these things that are 2 or 3 millimeters on these wonderful new digital mammograms. Of course, it's wonderful news. We can pick up these things at an early stage. However, the critics will say, how can you be sure that that tiny little area of pre-cancer will develop into a true cancer and then spread throughout the lady's body and kill her? You can't be sure. So if you do treat that, you're probably over-treating a proportion of ladies who will not die of that pre-cancer or true cancer. Over-treatment. The headline of the Daily Telegraph, 4,000 ladies harmed per year as a result of screening. Yes, there will be people who will be treated unnecessarily, if you accept the word unnecessarily. It's not that they're having the wrong treatment, it's not that we've misdiagnosed them. The diagnosis is right, they do have pre-cancer, but you can't be sure that that precancer will kill that lady. Now, of course, if you've got a lady of 95 and you've got precancer, then it's likely that she will die of something else. But, you know, even a lady of 55, you can never be sure whether that cancer, because it's so small, will be the cause of her death. And if you can't be sure, then the critics would say you're perhaps over-treating a proportion. Now, of course, one lady said to me when I mentioned this to her just last week, she said, well, you of course can't be sure. You could treat me for my breast cancer and I could walk out the door and be knocked over by a bus. So the bus killed me, not the breast cancer. So you could say I was over-treated. So you can see this huge uncertainty. And all these statistics, these 4,000 women that are so-called harmed, it's an estimate. They are looking at people who have mammograms and have cancer picked up and comparing it to a population who, for whatever reason, didn't have a mammogram and seeing how many of them die from breast cancer. A very, very rough estimate. But I think we have to accept that, yes, there will be a small proportion, and we'll come on to what sort of proportion, of ladies that we pick up with very early breast cancer that it might not kill them. And I think that, you know, this is very important in terms of what we said before, educating. That's why I'm so delighted that you've all come here this evening, so that you can make up your mind as to whether you really think that the benefits for you, not the general population, the benefits for you outweigh the possibility that you could be over-treated. Yes, as I say, we pick up precancers, very small, true cancers. We may pick it up in ladies in their 70s or 80s, and we don't know whether their precancer will be their cause of the death or whether they'll have a stroke the next week. We don't know the natural history of a breast cancer, but I have to tell you again, sorry to come back to this real people again, a real woman, if you tell her that there is precancer within her breast, I've never met anyone who will say, well, I've read that we could be over-treating, we're not sure that this could kill me, I'll just watch it. Let's leave it and see. You've got precancer in your breast, you want it out because you want to be cured. And I think that's the reality of the situation. I don't think I've met anyone who would say, well, if you can't be sure that this precancer will kill me, leave it and we'll see whether it spreads. Real patients. Next slide, please. So, I've confused you. I hope I have, because if I haven't confused you, then I've not been successful at telling you all the pros and cons. It's a difficult way to look at weighing up the benefits of early diagnosis, the benefits of avoiding a mastectomy, avoiding chemotherapy, having a 95% survival against the X-rays that we talked about, the possibility of being called back for unnecessary tests, possibly having treatment for a cancer that might never kill you, and the anxiety that it produces. What we have to really think about is, when you get the invitation for a mammogram, or if you're thinking about having your own mammograms, what are the risks of having the mammogram against the risks of saying, I don't want to know what's going on. What will be. What's going on in my breast is going on in my breast. If I develop breast cancer, so be it. If I don't, fine. So that's the risks of not having the mammogram. Now, I have to tell you, and I'm honest about this, I come as slightly biased. I was a medical student and a young doctor in the 1980s. Breast cancer was a killer. The majority of ladies that I saw that were diagnosed with breast cancer would die of breast cancer. They came with large cancers, spread to the lymph glands in the armpit, and very often, within 2 or 3 years, they were dead. Difficult to treat, very, very difficult. Ladies in the prime of life dying of breast cancer. Why? Firstly, they weren't aware of what a lump in the breast meant, because we're not as open we weren't as open about it then as we are now, and we didn't have screening. So ladies never had the opportunity to present themselves for a mammogram to have their breast cancer picked up at an early stage. Now, I think the Daily Mail said that banner headlines about 2 weeks ago, breast cancer bombshell. What was the bombshell? There was a report which was suggesting that in 10 years' time there will be 1 million women in this country who are survivors from breast cancer. That's the bombshell. That's the most wonderful news. What's happening is breast cancer is becoming a disease like the flu. It's becoming a disease like, having diphtheria used to be. It's now something that we can pick up at an early stage and we can actually deal with it. But only if we pick it up early. Next slide. So, again, just looking in a little bit more detail at this pros and cons. The risk versus benefit. As I've said, the radiation dose is very, very low and it's focused on the breast. 10 screening rounds, in other words 10 mammograms over a period of whatever it is, 20, 30 years, will still only increase your risk of breast cancer by a tiny percentage. The ratio of cancers that we can pick up on a mammogram in comparison to the ones that we may actually induce by having a mammogram is between 1 in 100 and 1 in 1,000. So for every 999 cancers that we pick up, we could possibly induce one extra cancer that wouldn't have developed if no one would have had mammograms. In fact, in all the studies that have been done, no one has ever shown that your chance of getting breast cancer is increased as a result of having regular mammograms. Next slide, please. So what programs are there for screening? Well, there's the National Health Service breast screening program set up in 1988, originally from the age of 50 to the age of 65. Each GP practice would be approached, and every lady between that age, 50 and 65, would be invited to come and have a mammogram every 3 years. Now, the age range is 50 to 70, and we're extending it to start at 47 to the age of 73. But even after the age of 73, and I don't think there's anyone here over the age of 73, you can request to carry on being screened at 75, 78, 80, if you want. As I say, it's every 3 years. Interestingly, the attendance, the average throughout the country of people who accept the invitation to come up for screening is about 80%. So 8 out of 10 ladies that are invited in the United Kingdom actually come up and have their mammogram. In London, I'm afraid, it's down at 50 to 60%. And one of the reasons that people like me come round to you is to spread this message. Come. If you don't have your mammogram, you're much more likely to die of breast cancer. 73% in Enfield. You can be assured that the quality of the mammograms and the quality of the assessment is excellent, because what we call the quality assurance is so strictly monitored. They monitor carefully how much radiation is given, how many x-rays are given in each mammogram. They work out every single unit that invites people for a mammogram, how many biopsies they do, how many cancers they detect, how many cases need surgery, etc., etc. And I have to tell you, because I attend these meetings regularly, that it is so carefully scrutinised. Every unit throughout England, Wales and Scotland is minutely assessed. It is one of the most amazing systems of making sure that the quality of the assessments, because it's very easy to stop the number of people coming back unnecessarily, is you say, oh, it's probably nothing to worry about, forget about it. So fewer people need to come back. The problem is, you then have more people who develop breast cancer 3-6 months after they've had their mammogram, what we call an interval cancer, So all these things are very carefully regulated to make sure that we get the balance right. Next slide, please. Aside from the routine National Health Service screening programs that we also have family history clinics. Remember at the beginning I told you that the risk of you developing breast cancer would be increased if your mother or your sister had breast cancer. We run a clinic at Chase Farm. I'm a consultant surgeon. I run the Chase Breast Unit. And at Chase Farm, we have a family history clinic dedicated to people with an increased risk of breast cancer. And we screen people every year because we know that their risk is increased. Not every 3 years, but every year. And every year, we pick up about 5 or 10 ladies with breast cancer, which is much higher than the national screening program, because don't forget we're doing it every year, and our pickup rate is double their rate, which really fits in with our concern that these ladies with a family history have a higher risk of breast cancer. The National Health Service breast screening program is now beginning to look at the highest risk patients. I don't know whether you've heard of people who carry a broken gene for breast cancer. If you carry that broken gene, your risk of breast cancer can be as high as 80–85%. Some ladies who know that they carry the gene elect to have their breasts removed. It's not the topic that I'm talking about today, but that's their choice. Whereas some say that's something I couldn't do, but I know that my risk of breast cancer is so high, so we watch them very, very closely. These ladies actually have regular MRI scans. I also run some private programs where we look at patients who are at slightly higher risk. Basically, any lady that is anxious about her breasts can come up and have a regular mammogram. That's run from the King's Oak Hospital, and that starts at the age of 40. Next slide, please. So, bit of a marathon, I'm sorry. I hope I've confused you, but I hope now you're beginning to see the message. Breast cancer is the commonest cancer affecting women. 1 in 8 or 9 will develop breast cancer, and it's very difficult to prevent. However, if we can diagnose it at an early stage, it leads to close to 100% cure with much less unpleasant treatment. The current screening program does involve X-rays, but the dose is low, and even the theoretical predictions of the harm it can produce is very, very difficult to assess. But we're very confident that it's going to be low. So therefore, when we talked about it before, the benefits of early diagnosis far, far outweigh these theoretical increased risks. And last slide. Yes, I will be the first to agree that we cannot be sure that not all the breast cancers, the pre-cancers, the tiny cancers that we pick up, will definitely kill that individual lady. And that is something that you have to bear in mind. Although, as I said to you before, the reality of the situation is that ladies want to know what's going on inside their breast, if only to know that everything's fine, and if there is something abnormal, they want it dealt with. And that's normal and sensible. Because what they're doing is, they're weighing up the pros and cons. In the same way as you decide whether to get into your car and drive home, if you were to spend 3 hours in an evening in the accident and emergency unit at Chase Farm, you would probably hesitate to get into your car the next day because you see all the harm that driving your car can cause. You know, the lorry that jumps the lights. But why do we get into our cars? Because we weigh up the pros and the cons. We need to get home, we need to pick up the kids from school, we need to get to do the shopping, etc. So, yes, we acknowledge the harm, we acknowledge the downsides, but because the benefits of getting into your car, because the benefits of going out to a restaurant and eating outweigh the risks of getting food poisoning, we make that assessment. Every time we cross the road, we make that assessment. And it's important that, as intelligent consumers, as it were, that when we are invited or when we think about having a screening test, we understand that there are some downsides, but the benefits far, far outweigh it. And this is the great danger that newspapers like the Daily Mail, who love to have a go at screening programs. So one week they're telling you that it's the most dangerous thing you could ever have is a mammogram, and then a few weeks later, headlines, only 60% of Londoners go for a mammogram. It's disgusting and disgraceful. Why? Because they're worrying people unnecessarily. The evidence suggests that the benefits far outweigh the harm. And therefore, as I say, I recommend that as a minimum, every lady has a mammogram every 3 years from the age of 47. And in fact, my gentle advice to all ladies over the age of 40 even, is if you've got small amounts of resource, even have a mammogram from the age of 40. It can save your life. I just finish off with the story of the elderly man that goes into the confessional and he says, "Father, I've been happily married for 62 years, but I have to tell you that last night I spent the entire night with two 18-year-old blondes, and we had intimate relations on numerous occasions." So the father says, "That's an amazing story." He says, "Tell me, when was the last time you came for confessional?" He says, "Oh, I've never been to confessional before, I'm Jewish." He says, "You're Jewish? What are you telling me this story?" He's telling you this story. He says, "I'm telling everybody this story." Why did I tell that? Because I'm telling you this story about breast screening. If I can save one lady's life, then that is the most amazing thing that I can ever do. And if you go away from here with this message, tell your friends, tell your relatives, then you could also be saving someone's life. So yes, read the papers, listen to the news, be aware, but don't allow it to stop you coming up, because it could save your life. Thank you very much indeed.
The message is loud and clear. Early diagnosis
leads to better outcomes, a lower risk of dying of breast cancer, and the treatment that you'll need usually is much less unpleasant.
Are we winning the battle?
Definitely. The number of ladies who die of breast cancer in this country has fallen by about 30% in the last 20 years, and it's continuing to fall. Even though the number of ladies who are diagnosed with breast cancer is going up, the number of ladies who die is falling.
So breast screening is a must?
I think that every lady has to make their own decision on it, but my view is that the benefits outweigh the risks. Every lady must understand that there are downsides, but once they've made that calculation, my hope would be that they'd get themselves checked out.
Doctor, thank you very much, and every success.
Thank you very much. The success for all the patients is the most important thing.